Palpitation. Palpitation is an unexpected or unpleasant awareness of the heart beating in the chest. Detailed history taking can help to distinguish the different types of palpitation. Ask about nature of the palpitation. Is the heartbeat rapid, forceful or irregular? Can the patient tap it out? Timing of symptoms, speed of onset and offset, frequency and duration of episodes, precipitants for symptoms or relieving factors, associated symptoms, presyncope, syncope or chest pain, history of underlying cardiac disease. Healthy people are occasionally aware of their heart beating with normal sinus rhythm, especially after exercise or in stressful situations such as when waiting for an interview or examination. The sensation is often more common in bed at night, and slim people may notice it when lying on their left side. Ectopic beats, extrasystoles, are a benign cause of palpitation at rest and are abolished by exercise. The premature ectopic beat produces a small stroke volume and an impalpable impulse due to incomplete left ventricular filling. The subsequent compensatory pause leads to ventricular overfilling and a forceful contraction with the next beat. Accordingly, patients often describe missed beats, sometimes followed by a particularly strong heartbeat, jolt or thump. Supraventricular tachycardia produces sudden paroxysms of rapid, regular palpitation that can sometimes be terminated with vagal stimulation, using Valsalva breathing maneuvers or carotid sinus pressure. It often affects young patients with no other underlying cardiac disease. Ventricular tachycardia can produce similar symptoms but is more commonly associated with presyncope or syncope, and tends to affect patients with cardiomyopathy or previous myocardial infarction. High-risk features that increase the likelihood of a life-threatening arrhythmia such as ventricular tachycardia include previous myocardial infarction or cardiac surgery, associated syncope or severe chest pain, family history of sudden death, of Parkinson-White syndrome, significant structural heart disease such as hypertrophic cardiomyopathy or aortic stenosis. Now, descriptions of arrhythmia. Extrasystoles. Site, no site. Onset is sudden onset. Character is jump, missed beat or flutter. There is no radiation associated. There is no associated features. Timing is brief. Exacerbating relieving factors. Fatigue, caffeine, alcohol may trigger. Often relieved by walking. Increases sinus rate. Severity mild usually. Sinus tachycardia, site absent. Onset is gradual. Character regular, fast, pounding. There is no radiation. Associated features is anxiety. Timing a few minutes. Exacerbating or relieving factors. Exercise or anxiety may trigger. Severity mild to moderate. Supraventricular tachycardia, there is no site. Onset is sudden onset with jump. Character regular and fast. There is no radiation. Associated features includes polyuria, lightheadedness, chest tightness. Timing minutes to hours. Exacerbating relieving factors, usually at rest. Trivial movements, example bending may trigger. Vagal maneuvers may relieve. Severity moderate to severe. Atrial fibrillation, there is no site. Onset is sudden. Character irregular. Usually fast, slower in elderly. There is no radiation. Associated features include polyuria, breathlessness. Syncope is uncommon. Timing is variable. Exacerbating relieving factors. Exercise or alcohol may trigger, often spontaneous. Severity very variable, may be asymptomatic. Ventricular tachycardia, there is no site, onset, sudden onset, character regular and fast, there is no radiation. Associated features include presyncope, syncope, chest tightness. Timing variable, exacerbating relieving factors. Exercise may trigger, often spontaneous. Severity, often severe. Now, syncope and presyncope. Syncope is a transient loss of consciousness due to transient cerebral hypoperfusion. Causes include postural hypotension, neurocardiogenic syncope, arrhythmias, and mechanical obstruction to cardiac output. The same mechanisms may lead to a sensation of lightheadedness and impending loss of consciousness without progressing to actual loss of consciousness, that is called presyncope. The main differential diagnosis of syncope is seizure, while lightheadedness and presyncope must be distinguished from dizziness or vertigo due to non-cardiovascular causes. In patients who present with syncope, ask about circumstances of the event and any preceding symptoms such as palpitation, chest pain, lightheadedness, nausea, tinnitus, sweating, or visual disturbance. Duration of loss of consciousness, appearance of the patient while unconscious, and any injuries sustained. A detailed witness history is extremely helpful. Time to recovery of full consciousness and normal cognition. Current driving status, including occupational driving. Symptoms related to medication. Angina, aggravated by thyroxine or drug-induced anemia. Example, aspirin or NSAIDs. Dyspnea, beta blockers in patients with asthma. Exacerbation of heart failure by beta blockers. Some calcium channel antagonists such as verapamil, diltiazem. NSAIDs. Palpitation, tachycardia and or arrhythmia from thyroxine beta-2 stimulants such as salbutamol, digoxin toxicity. Hypokalemia from diuretics, tricyclic antidepressants. Syncope, presyncope. Vasodilators such as nitrates, alpha blockers, AC inhibitors, or angiotensin II receptor antagonists. Bradycardia from rate-limiting agents such as beta blockers, some calcium channel antagonists, verapamil, diltiazem, digoxin, amiodarone. Edema, glucocorticoids, NSAIDs, some calcium channel antagonists, nifedipine, amlodipine. In patients with presyncopal symptoms of lightheadedness or dizziness, ask about exact nature of symptoms and associated features such as palpitation. Precipitants for symptoms such as postural change, prolonged standing, increased emotion or exertion, frequency of episodes, and impact on lifestyle. Possible contributing medications such as antihypertensive agents. Postural hypotension, a fall of more than 20 mm mercury in systolic blood pressure on standing, may lead to syncope or presyncope. It can be caused by hypovolemia, drugs, or autonomic neuropathy and is common in the elderly, affecting up to 1/3 of individuals over 65 years. In simple faint and other forms of reflex syncope or presyncope, abnormal autonomic reflexes produce a sudden slow heart rate, bradycardia, and or vasodilatation. This may be triggered in healthy people forced to stand for a long time in a warm environment or subject to painful or emotional stimuli, such as the sight of blood. There is typically a prodrome of lightheadedness, tinnitus, nausea, sweating, and facial pallor, and a darkening of vision from the periphery as the retinal blood supply, the most oxygen-sensitive part of the nervous system, is reduced. The person then slides to the floor, losing consciousness. When laid flat to aid cerebral circulation, the individual wakes up, often flushing from vasodilatation and nauseated or even vomiting due to vagal overactivity. If the person is held upright by misguided bystanders, continued cerebral hypoperfusion delays recovery and may lead to a seizure and a mistaken diagnosis of epilepsy. In patients with hypersensitive carotid sinus syndrome, pressure over the carotid sinus may lead to reflex bradycardia and syncope. Arrhythmias can cause syncope or presyncope. The most common cause is bradyarrhythmia caused by sinoatrial disease or atrioventricular block, Stokes-Adams attacks. Rate-limiting drugs are a common cause of bradyarrhythmia. Supraventricular tachyarrhythmias like atrial fibrillation rarely cause syncope, whereas ventricular tachycardia often causes syncope or presyncope, especially in patients with impaired left ventricular function. Mechanical obstruction to left ventricular outflow, including severe aortic stenosis and hypertrophic cardiomyopathy, can cause syncope or presyncope, especially on exertion, when cardiac output cannot meet the increased metabolic demand. Massive pulmonary embolism can lead to syncope by obstructing outflow from the right ventricle. Associated features are usually apparent and include acute dyspnea, chest pain, and hypoxia. Cardiac tumors such as atrial myxoma and thrombosis or failure of prosthetic heart valves are rare causes of syncope. Now, edema. Excess fluid in the interstitial space causes edema, tissue swelling. It is usually gravity dependent and so is seen especially around the ankles or over the sacrum in patients lying in bed. Unilateral lower limb edema may occur in deep vein thrombosis. Heart failure is a common cause of bilateral lower limb edema, but other causes include chronic venous disease, vasodilating calcium channel antagonists such as amlodipine and hypoalbuminemia, and elevated jugular venous pressure strongly suggest a cardiogenic cause of edema. Inquire about other symptoms of fluid overload, including dyspnea, orthopnea, and abdominal distension. Other symptoms of cardiac disease: infective endocarditis, microbial infection of a heart valve, frequently present with non-specific symptoms, including weight loss, tiredness, fever, and night sweats. Embolization of intracardiac thrombus, tumors such as atrial myxoma, or infective vegetations may produce symptoms of stroke, acute limb ischemia, or acute mesenteric ischemia. Advanced heart failure may result in either abdominal distension due to ascites or weight loss and muscle wasting, that is called cardiac cachexia, due to prolonged catabolic state.